we're going to start with stage one. And stage one is a lot of things. There's a lot of stuff going on here. There's really two moving parts. There's two agenda, which is building positive expectancy and a therapeutic relationship, but there's also the preparation and the assessment process. So I've had to split those up, and ideally, probably in the really real world of clinical practice, you would do the assessment before you would begin to build the therapeutic relationship, and before you build expectancy. But for the purpose of today, of this training, I'm going to do that opposite. We're going to first talk about the principles of stage one, the therapeutic relationship and positive expectancy, and then move on and do assessment. I'm going to walk you through how to do a good diagnosis, how to do outcome measuring, how to manage those early treatment interventions. But I want to start with the most important things, and that is positive expectancy. So I'll let you read that. I won't read that for you, but you can, while I'm prattling on here a minute, you can read through that slide. It's also in your handouts. In all this meta-analytic research that we talked about earlier, when you look at them, when you look at multiple regression that picks out what are the most impactful factors, you find that positive expectancy is frequently cited as number two. It's always up there in the high order of with the highest R-squareds, meaning the most variance in scores is attributed to that factor, which is positive expectancy. And that's what it's called in the research, is positive expectancy, unless the researcher is a little bit cynical. And then the researcher calls that same phenomena placebo. We're talking about the same thing. But for our purposes, we're going to call it in normal, everyday pedestrian language, hope. Hope is a crucial therapeutic process for working with trauma survivors. That's your job. You are the ambassador of hope. Doesn't matter how skilled you are, how degreed you are, how many initials you have after your name. If in those first couple of sessions you cannot efficiently use language to create a vision for your client of an alternative to the death march that they're on, and be able to sell that to them, be able to help them to start to believe that maybe this is possible for them, then you don't ever get a chance to apply all those skills that you got, because your clients don't come back. Think about that in your own life. How many of you have ever had any scary medical conditions? Something that frightened you? And think about the impact that the health care professional, that the way that they presented to you the diagnosis, and the way that they talked to you about treatment, the way they talked to you about prognoses, how much of an impact did that make upon the way you engaged in participating in your own treatment? Good or bad? It had a significant impact, didn't it? When I do the live training, I always say here, would you like to have a formula for success that is foolproof for you and everybody else? Would you like to know a foolproof formula to maximize your success for the rest of your life? And I guarantee you it'll work. And everybody says, yeah. And I say, well, it's really simple. The formula for success in your life is all you got to do is everything you don't want to do. I mean, that's the pathway to success. And people who are successful generally do a better job of tackling the things that they don't want to do. The rest of us kind of shrug it and procrastinate it and put it off. And people who are really successful confront and do the things that they don't want to do. And I would ask you, how much easier is it to do the things you don't want to do when you know that there's going to be a positive outcome coming from it? So positive expectancy is the grease. It's the lubrication. It's how you get clients who are scared to death to begin to take risks, to begin to step out. Is I've got to be able to tag those behaviors. If they will put the effort and energy in, I need to be able to talk about that in a meaningful way that helps them to start to believe that maybe they can have some of this. So, the question then, and let me just do a quick little study for you. This has always been really cool for me. This was in Hilgard's book on hypnosis and the treatment of pain, and it's pretty cool. Stanford University, I think this was in '72, did a study with 4 analgesias. They looked at aspirin, acetaminophen, Demerol, morphine sulfate, and they double-blinded with patients, and they got 190 patients to agree to not get their morphine and instead get sugar pills. And the people who were administering them, the pills to them, didn't know what they were given. So after a year, and they got enough people in to be able to make power in all 4 of those categories, and then they crunched the numbers, and what they found was that between 52% with aspirin, 58% with morphine, and the rest of them were in that window between 52 and 58% of the effectiveness of the analgesia, of the pain relief that those patients got, was the expectancy, not the dope. So get your head fully around that. That more powerful than the most powerful dope on the planet at the time was the expectancy of the dope. That's a big deal. So when some bloviating academic looks at me and says, that's just placebo, it ain't just anything. When the placebo effect, when the expectancy effect is greater than the technical effect, which is always the way it plays out in mental health, is that the expectancy of the thing is always more powerful than the thing. So it is incumbent upon us to maximize that, to be able to get that with our clients, because what it does is it makes our treatments work. Is that the expectancy is how it is what catalyzes. It's the delivery system. It's the coding that delivers the medicine. So the DSM-3, the DSM-3R, the DSM-4, and the DSM-4TR, from 1980 until 2013, the diagnosis of PTSD included a symptom that was called foreshortened future. It's not in the DSM-5, but it was in all previous iterations of the DSM. What is foreshortened future? It's hopelessness. For a trauma survivor, hope is dangerous. Hope is threatening. Those of you watching this, how many of you have ever been to the Louvre in Paris? For those of you who have ever been to the Louvre, did any of you go to the Rodin room? And my scalp tingles when I think about this. I remember I was walking through the Louvre, and I had my little, it was a self-guided tour, and I had my headphones on, and I was listening to it, and it said, you're now approaching the Rodin room. And I walked into the Rodin and saw all his sculptures, and I turned and I saw his sculpture of the Gates of Hell. And it viscerally knocked me backwards. I mean, it was such a tortured and evocative piece of art that it physically knocked me back. And the banner at the top of that was what Virgil said in the Inferno, which is, I think the hallmark of traumatic stress. Abandon hope, all ye who enter here. That's what happens to a trauma survivor, is they abandon hope. They let it go because it hurts too much and it's too scary to believe that there's going to be something good happening, because it makes them vulnerable, so that they prune that back in. They are not willing to have positive expectancy. Instead, it is, I need to be on guard for the next bad thing that's happening. So you see the challenge. How do we get hope into the hopeless? Second most important ingredient in treatment, evidence-based, is our need to generate expectancy, hope with our clients. How do we do that with and for somebody who perceives hope as threat? Excuse me. It's a conundrum. It's hard. And while I don't have an empirical answer to that, I will one day. My hope is that one of my research projects that I've got in front of me that I really want to do before I die is I want to empiricize positive expectancy in the same way that Scott Miller has done a really nice job of turning into an empirical process the therapeutic relationship. I want to do the same thing with positive expectancy. And I've got some ideas about that. I've been thinking about it for a lot of years. But my answer is no more right than yours. How do you get hope into the hopeless? There's a bunch of stuff you can do. There's technical things you can do. And I thoroughly support and advocate taking at least even an online course on motivational interviewing. And you learn how to roll with resistance, that they say. Learn how to be able to be collaborative. Learn how to point out the discrepancy between who they say they are, where they want to go, and the way that they are behaving, and being able to do that in a Socratic questioning kind of way. You know, all of those things which you can do technically to maximize that. There are interventions that are designed to do that. But I want to say that I'm absolutely certain that that's not enough. And I'd like to illustrate how and why that's not enough. I've always, as I shared with you at the beginning of this course, I've always been a junkie for transformation. I've always been about helping people transform their lives. And as a 20-something, I worked in an agency, and I would have my clients, they'd come in my office and I'd say, sit down, we're going to change your life. And I meant that. I was totally 100% in belief, cathected to this idea that this person sitting across from me, through our work, we were going to transform, that they were going to get a transformed life. And then I spent that first session with them. And I got to hear about trauma after trauma after trauma after trauma. You know, folks with ACE scores of 8, 9, 10. And I heard just all of this: childhood sexual abuse, childhood physical abuse, poverty, and all of this horrible stuff that they had endured. And what do you suppose is going on inside with me as a 20-something? Hearing all of that, I got scared. Because you see what they were doing, they were transferring the responsibility of that to me. As they shared it with me, it now became my responsibility to do something about and with that for them. And I started going, ah. Inside I was, of course, inside I was terrified. Outside I had a calm veneer. And the second half of that session came, and I got to hear about the paucity of resources that they had. They didn't have financial resources. They didn't have language skills. They didn't have support networks. They didn't have very much to work with. So that needle, which I began the session totally 100% intentional towards being an instrument of transformation, by the end of that session, that needle had fallen all the way over here to palliative care. I no longer believed that this person sitting across from me could transform. And I only hope that I could relieve a little bit of their suffering. But at the end of that session, I still did and said all the right stuff. I still did technically the right things. I looked at him and I said, well, we got some stuff that we can do that's really, really helpful for you. And I watched my clients lean back in their chair and cross their arms like this. And what do you suppose I wrote in the case file about those clients? I sure did. Resistant. I've been doing a lot of supervision for the past 20 years. And the first 5 years that I did supervision, and I saw a clinician write the words resistant, or I heard them use the language of resistance, I got a little bit testy with them. I confronted them and tried to get them to relinquish that. Today, I am much more compassionate. Because what I realize today is that when a clinician uses the language of resistance, it's usually from one part ignorance and 2 parts dysregulation. That they have become so myopic in their fear, in their dysregulation, they have lost neocortical functioning and they have become myopic. And what's happening is that they are increasingly believing there is only one way for this person to heal, their way. And in their anxiety and compulsivity, what they're doing is that they are becoming increasingly coercive, increasingly trying to push their client into perceiving the process from their perspective. That's not trauma-informed care. And I want you to look at it with me this way. When you use the language of resistance, you are defining the paradigm. You can't have resistance unless you're pushing. You got to have the push before you can have resistance. Because when you stop pushing, you stop having resistance, you just have fear. Appropriate fear. Looking through the lens of their history, seeing their entire history, that your client showing up, being afraid of swallowing the blue pill that you're offering, is good judgment on their part, based upon their learning history. So, as I look back on my experiences as a 20-something, what I start seeing is that my clients weren't resistant at all. And what I've come to understand is that when I'm sitting across from a trauma survivor, I'm sitting across from the most intuitive people on the planet. People that have high ACE scores learned to have little antenna that they could feel when things were off kilter. And what was happening with my clients is that they were feeling me giving up hope on them. They were feeling me being dysregulated. And they couldn't articulate that more than the man in the moon. You would have interviewed them after the session and said, I don't know, something felt hinky in there. But what was happening was that they perceived me on some level. Their little mirror neurons were perceiving me, having given up on them, and feeling me in this state of dysregulation and fear. And they were not going to hitch their wagon to a therapist that on some level they knew could not take them to where they needed to go. That's not resistance. That's good judgment. Anytime that a trauma survivor is sitting across from a therapist that cannot or will not regulate themselves, their refusal to participate in treatment is evidence of their good judgment. They don't know how they know. They just know that this person cannot take them to where they need to go. So how do we get hope into the hopeless? Well, what I'm absolutely certain of without any data, except 10,000 clients, is I got to believe. My clients need to feel me, believing. They need to experience me, knowing that they can heal, that they can resolve. And it's been really helpful learning more and more information and knowing that I've got it and having enough experiences in my back pocket, knowing that as my client begins to practice self-regulation, that they're not going to be suffering anymore. So that helps a whole lot. But still, it takes me walking out on the limb and holding that up for them. And somebody that's helped me to do that a whole lot is somebody upon whose shoulders that I stand for this course. And I introduced him to you briefly when I had all the 20th century luminaries, and I want to spend a moment talking about Viktor Frankl. Because everything I do, every time I teach a course, every time I see a client, every time I do any work in this field, it is standing on Viktor's shoulders, and it is infused with his spirit. For those of you who don't know, Viktor Frankl was a neurologist, psychiatrist in Vienna. He got married in 1939. In 1941, several of his colleagues came. He was well liked by his peers. In 1941, early 1941, several of his colleagues came to him and offered him and his wife 2 tickets to the UK because it was becoming increasingly dangerous for people of the Jewish faith to be in Europe, especially Germanic Europe, and Austria was kind of one of the epicenters of where all the ethnic cleansing was happening. And Viktor said, "Nope, I'm not going. I've got my family here. I've got my patients. I'm staying." And in June of 1941, both he and his wife were captured by the SS. They were taken to a holding camp and then split up, transferred. She was moved around to multiple different camps, died in 1945. He never saw her again. Just a few weeks before liberation, Viktor was he was actually moved back and forth between 2 different camps, 2 of what people say are 2 of the worst Nazi death camps that there were, Auschwitz and Dachau, where he was starved, where he was tortured, where he was without clothing during the polar winters, and where he was forced at gunpoint to perform atrocities upon his friends. What do you suppose Viktor's quality of life was while he was in Auschwitz, while he was in Dachau? Pretty horrible, right? Pretty bad set of life circumstances. Well, the answer to that question is why I believe that the single most important book that a person can read in preparation for sitting across from a trauma survivor is Man's Search for Meaning. For those of you who have read it, you know exactly what I'm talking about. For those of you who haven't, you're in for a treat, because the first 119 pages of Man's Search for Meaning, Viktor, if you think about what I've done already in talking about narrative and memory, you could start to have, and for those of you who have read it, it's worth a reread. Because what you'll start being able to look at it now is to see that, wait a minute, this is a trauma narrative. This is Viktor taking all of those sensory fragments and constructing language around it so that it would relegate to his past, so that he could heal it, so he could resolve. He didn't have a therapist to work with him through that. He didn't know what he was doing. He just had a felt sense that this needed to come out. And it comes out beautifully. For those of you who've read it, it's almost poetry. I mean, it's beautifully wrought language describing horror and squalor of a Nazi death camp. And you don't have to get very far into that book. I mean, as he's describing those experiences of starvation and pain and frigid temperatures, 5 pages into that book, you start seeing that there's this emergence of a meta-narrative. There's all this description of the experiences in the Nazi death camp, and then he starts talking about his internal experiences, of how he's able to find joy, peace. Oh. You know, I train this a lot, and every time I talk about this, it moves me. It moves me. Viktor Frankl was able to find joy, peace, purpose, meaning, and love in a Nazi death camp. That's not nothing. Viktor Frankl was able to develop and maintain some degree of quality of life while he was interned in a torturous existence. That's a big deal. And then he left us a chronicle of it, which I think is his gift to humanity. I have an ACE score of 9. I read Man's Search for Meaning the first time in my life when I was 15 years old, and it was my first conscious experience of hope. And I think on a lot of levels I am alive today because of Victor. That book, having reread it many, many times, has been a source of comfort and hope for me to keep me going at times. And I want to share with you the gift that Victor's given me. And my hopes is that this serves you at 10% of the level that it has me throughout my career. And here's what Victor's taught me. This is Viktor Frankl, according to Eric. Is from Victor I've learned that no matter who you are, no matter how many times you've been raped, no matter how many limbs you've lost in combat, no matter what life-sucking disease you are afflicted with and how few days you have left to live, if you have an aggressive form of cancer, glioblastoma, and you've got 1 week left to live, what I'm absolutely certain of is that you can have a really good life in that last week. You can have a good life today, independent of the external contexts, of the external situations. And for me, as a change agent, that has been gold. That's precious. Because what it's allowed me to do is to begin to work with my clients by helping them to take their focus and energy off of what is outside of their control and to put their focus and energy where they have power. And when I start doing that consistently with my clients, they start finding that they can mine and experience joy, peace, purpose, meaning, and love today. And if you're having regular experiences with joy, peace, purpose, meaning, and love, you're having some degree of quality of life. Is that valuable? It has been for me, because what it's meant for me is that today when I sit across from a trauma survivor, and I will say part of this is walking through this process with thousands of people. But what I have today and what Victor gave me is the ability to keep my hope for my clients incandescent. That no matter how hopeless they are, no matter how dark, how scared, how entrenched they are, it lets me to continue to show up and be in the context of them without having to push, but continuing to hold up the knowledge that they can transform and they can have a different and better life. And that served me well. And you know what? Betting on trauma survivors is a good bet. Because when you look at their history, and when we get into the assessment process, I'm going to show you some really cool things to do where you end up with data, where I can start to pull out of the file all of the information that I've collected from them, and I can hold it up to them, and I can have them look at their life timeline, and I can go to them, you know what? The hard part of your life is over. The hard part of your life was surviving all of this stuff. And you did a lot of that while you were a child. This part, the therapy part, is not hard. It's just scary. It's not hard. That was hard. This is not. It's just scary. And I promise you, you're going to be able to walk this through and get to the other side. You survive a sexual predator in your family. You survive an alcoholic parent. You survive aggressive caregivers. You're going to survive me. I promise you. You're going to get through this. So Victor has been a really wonderful and potent catalyst for helping me to be able to sustain that sense of positive expectancy and continue to bring it forward at all phases of treatment. And this is something that you've all done. You all do it, or you wouldn't be able to stay in practice. But most of you, the way that you've done this is you've done it instinctually. What I'm going to ask you to do as a result of watching this course is that when you go back to work tomorrow, or whenever you go back to work, and the next time you sit across from a client, I'm going to ask you to take 5 seconds during that session and ask yourself, what can I do to just move up a tick the positive expectancy? How can I foster a little bit more hope here? Because the more of that I'm able to get activated with my client, the more they are willing to walk into doing the things that they are afraid to do. And I'm going to be asking them to do a whole lot of things that they're afraid to do. And so I need to have a requisite amount of positive expectancy for that to happen. I thought I had read everything that Victor had ever written. And then I came across this quote a few years back. And it says, between stimulus and response, there is a space. In that space is our power to choose our response. In our response lies our growth and our freedom. What about that? Think about the ramifications of that quote. And I would ask you to identify what 3 simple declarative sentences better articulate what it is that we do with our clients than those 3. That's what we do. And when you start thinking about trauma survivors and you start understanding the way the autonomic nervous system works, which is where we're headed here in a little bit, when you start understanding that, what you start seeing is that trauma survivors have stimulus that, because of the intrusion of their painful past learning, they are perceiving that stimuli as a threat. So the energy in their body cranks up, they lose neocortical functioning, and that space slams shut. So they don't have any space to make choice. So that instead of choice, what trauma survivors have is reactivity, instinctual behavior that is either aggressive or avoidant, fight or flight. They are trying to get away from or attack the thing that they are perceiving as threat. And what that ends up meaning is that they are constantly in the same behavior. They're stuck in Groundhog Day. And for me, with an ACE score of 9, I was right at 30 years old before I started getting it that I didn't have to fight every time somebody disrespected me. I mean, I knew that conceptually when I was in my best self. I could articulate that, sure. But in the moment, when somebody said something smart or snarky or disrespectful to me, it immediately produced an aggressive response. Like, I could not have that aggressive response. And it had some negative consequences. My nose has been broken 7 times. I've had some negative consequences from that reactivity. Hopefully, with the material that I've done already, I have established myself as a practitioner scientist. I have done good and thorough research on this course. I have published in major journals. I am a closet scientist. Hopefully I've established those credentials with you. I want to step over here into the spirit for just a second. The spirit of this work. When I do trauma therapy right, what I become is a midwife. I am practicing midwifery more than I am medicine. And what it is that I am busy birthing is selves. Because when I start teaching clients how to regulate their autonomic nervous system, when they start having some space, when they have these stimuli, and they can start to open up and keep open that space, then they've got a neocortex and they can ask themselves, how do I want to be when people disrespect me? Oh, I never knew that I had a choice. How do I want to be when I don't have enough money to pay my bills? How do I want to be when my children are screaming? And with a regulated autonomic nervous system, what we get to watch and bear witness to is our clients now leaving our office and getting to be who they choose to be. Instead of what their painful past experiences have programmed them to be. And I just don't know that there's ever anything that I do that is more meaningful than that. That I get to be the impetus and the catalyst for human beings going forward, choosing who and how they want to be. That's a pretty sweet thing. It's a pretty heady piece of business to get to do that's really different than just symptom resolution. And I hope that intrigues and challenges each of you to begin to find the ways in which you are losing your choice and your space is collapsing. And that's become kind of a fun way, because I tell all my clients this little quote, and I kind of, there's this quote that really is meaningful for me. And I tell them what it is. And then as we go through treatment and they're starting to say, well, my wife, and I say, oh, your space just collapsed, didn't it? How do you want to be when your wife is being snarky with you? Well, she needs to, yeah, well, forget about her. You're the one that's breaching your integrity. How do you want to be? And we got traction. We got movement now. And we start helping our clients stop blaming the external environment and begin to gain traction on who and how they want to be. And this is just a really nice conceptualization of helping our clients to get in that space more and more and more often as a result of treatment. I hope that you find that useful.